I want to thank everyone for staying. It's quite late. It's at the end of the week, so I know we're feeling a little tired, but I'm hoping to energize everybody with this talk. I'm also very passionate about this topic. It's driven a lot of my aspirations to be a doctor as well as a clinician researcher. I do want to say that I'm going to depart a bit from speaking about the biology of medicine. I'm not speaking about ancestry today. Today I will be talking about groups of patients, or the things that I will talk about will apply to groups of patients who've experienced historical institutional oppression and bias, such as African Americans in this country. So I have nothing to disclose. The objectives of this talk will be to briefly describe broad and social economic disparities for African American patients in the United States. Then I'll touch very briefly on some disparities in clinical care and how that applies to patients in nephrology, and then end on reviewing strategies for confronting and decreasing disparities. So I like to start with a case that always kind of really drives what I'm going to say in my presentations, but there was a patient, NB, who I saw on the inpatient dialysis service. She was a 24-year-old female with history of sickle cell disease, pulmonary hypertension, end-stage renal disease from her sickle cell disease, who basically presented in pain crises. Her vital signs showed that she was very hypertensive. Her physical exam was notable for her being in moderate distress. She had signs of volume overload, lower extremity edema. Her labs showed a hemoglobin of 4.8, which was below her hemoglobin of 6, and a chest x-ray confirmed hypervolemia with small bilateral pleural effusions. So she was admitted for blood transfusion, pain control, and dialysis treatments. A little bit more about her social background. She had a very difficult social background. So she was lost to follow-up, and she was essentially bouncing around in Pennsylvania between Pittsburgh, Philadelphia, and Johnstown, living with family members, halfway homes. She had 2 young daughters. The father was in prison, and so she was a single mother trying to manage a family on her own, essentially. So when I looked at the chart, as I classically do for patients who have high social needs, I saw that she had been admitted at least 18 times between January of 2017 and June of 2019 for pain crises, all for pretty much the same admission. So I started to notice some buzzwords that were popping up in her medical chart quite consistently. Poor insight, non-adherent, unlikely to be sickle cell pain, missed dialysis, poor compliance, over-medicated with pain meds. And the most consistent phrase I saw was, discharge disposition, this patient was discharged to home in good condition. So you can imagine being admitted 18 times and really questioning, is that the case here? So questions to consider as I move forward with these objectives, but what is the best treatment plan for a patient like this? High social needs, ESRD on dialysis. And then another question to kind of ponder is, when you see patients like this and you're reading through their 18 admissions, do you really feel like you know this patient? Do you feel like you've formed some conclusions about this patient? Does it bother you? Do you get kind of riled up about these things? So let's just think about that as we move forward. So economic and social disparities among African Americans in this country. So African Americans comprise 14% of the population. And this graph on the left is from the U.S. Census Bureau from 2019 that shows consistent median household income disparities between the different racial groups in this country. And so as you can see with this blue line, white non-Hispanic patients have had persistently higher median household income compared to black patients. As of 2018, the median household income for whites was $70,000 as opposed to $41,000 for black patients. And similarly, looking at median wealth for racial groups in this country, so wealth is defined as the total market value of intangible and physical assets minus all of your debts. And so it's very important when thinking about access for patients. And you can see on the left, in between 1983 and 2013, that whites have a 13 times greater net worth compared to blacks. And so as of 2013, this is from Pew Research Center, which is a nonpartisan think tank that publishes social and economic data in this country, whites had median net worth of $141,000 as opposed to $11,000 for African Americans. I do want to note that these vertical columns in gray represent recessions over the years, and you can actually look and see each time there's a recession, African Americans consistently have a much harder time kind of rebounding to where they were post or pre-recession. So, very important to note. Again, thinking about education disparities, this was also from the Pew Research Center, looking at disparities over time, which I tend to look at trends. And you can see that amongst adults over the age of 25, white patients consistently have had greater, at least a bachelor's degree compared to blacks. So as of 2015, 36% of whites over the age of 25 had at least a college degree, as opposed to 23% of black people. So what am I getting at by looking at these kind of broad trends? I'm really getting at the social determinants of health, which is defined by the World Health Organization as the conditions in which people are born, grow, live, work, and age. And these social circumstances that you can see here, income, racial segregation, food insecurity, availability of transportation, are really powered by the distribution of resources at the local, national, and global level that really drive health inequities in this country. So let's take an example. Let's look at an example of how social determinants of health, or several, really drive health inequities. And so this is a map of Boston. So I lived in Boston for 10 years. This city is known for having high neighborhood segregation, and this came out of the Boston Public Health Commission in 2017, looking at the effects of neighborhood segregation amongst different races. And so you can see by the different colors, there's certain neighborhoods that have the higher proportions of race compared to others. So in the blue, these are neighborhoods that have majority white residents. In the orange, you see neighborhoods that have majority black residents. So looking at those who have less than a high school diploma in terms of education, you can see the same neighborhoods that I showed you that have a high proportion of black residents is where it's really concentrated in the city. Similarly, when we're looking at rates of unemployment, you can see the trend again. It's concentrated in the same neighborhoods that have a high proportion of blacks. Again, looking at median household income, I showed national trends. These are trends in Boston, same kind of trend in its neighborhood segregation. And lastly, the amount of residents who are living below the poverty line are really concentrated, again, in the neighborhoods that have a higher proportion of black residents. So what does this mean? So in 2006, a research group out of Boston University did an age-standardized early mortality analysis, looking at the different neighborhoods in Boston and what that meant. And doing that analysis, they showed that there was a life expectancy difference of 33 years between Back Bay, which is majority white residents, and Roxbury, which is majority black residents. It's just a kind of an example of how social determinants of health translates to clinical outcomes. So let's touch briefly on disparities in clinical care and how we can think about this further in the nephrology community. So in 2002, the Institute of Medicine, now the National Academy of Sciences, published this report called Unequal Treatment, where they described disparities in care for African American patients and other ethnic disparities in this country. And we know that we have disparities in kidney disease, cardiovascular disease, cancer, palliative and end-of-life care, and et cetera. So I would encourage everyone to look at this. You can view it online free of charge. It's really a phenomenal publication from top researchers, policymakers, et cetera, in this country. And so looking at ESRD specifically, we see that there's also disparities in the incidence of ESRD. Looking again over time, we see African Americans in this top green line have consistent higher rates of ESRD incident compared to other racial groups in this country, whites being in this line and Asians and then American Indians in the yellow line. So persistent disparities over greater than a decade period. And so what does this mean in terms of our population? So I'll highlight some brief studies looking at disparities in care in nephrology. And so this study was published in 2018 by Dr. Purnell and Deirdre Cruz and others who are probably sitting in this room, looking at trends of racial disparities in live donor kidney transplantation. And what they found was in between 1995 and 2013, they looked at about 450 or so thousand patients. The rates for white patients who received a donation increased from about 7% to 11% between 1995 and 2014. For black patients, that rate actually went down. So it went from initially 3% to 2.5% or so by 2014. And so the authors postulated that, again, thinking about social determinants of health, education, neighborhood segregation, income, perhaps were driving these disparities. And of course, that would impact referral to nephrology care. And then that would also impact the timing and quality of discussions about live donor kidney transplantation. You can imagine if you're rushing, if you're really close to needing dialysis, how much time do you have to build with your clinician and how much time do you have to actually talk about this and prepare for that? I thought that was really phenomenal that they had, they looked at these trends and identified them. And then similarly, sticking to trends and thinking about clinician and patient relationships, I did an analysis that was published in 2016 on looking at end-of-life care and intensive procedures that are received amongst hemodialysis patients. So this is an area of research that I'm very passionate about. And so we looked, using USRDS data, we looked at around 600,000 or so patients on maintenance dialysis and how the proportion of intensive procedures, so CPR, mechanical ventilation, feeding tubes, that they received in the last 6 months of life. And overall, we saw that the proportion of intensive procedures increased for all patients over this time period of 2000 to 2012. And then we stratified these curves by age, race, and ethnicity, and found some differences there as well. So for the dark line, for younger patients, we saw consistently more intense care for those patients compared to the lighter line, older patients, which is consistent with literature that shows that younger patients typically receive more intensive care. But what was very striking was that if you collapse these age stratified curves and just looked at the different race and ethnic groups, they were very parallel curves that showed that Hispanic and non-Hispanic blacks consistently received more intensive procedures at the end of life compared to non-Hispanic whites. So we were limited in this study, it's an observational study, to actually glean what that meant. And there's been a lot of data that looks at disparities at the end of life for patients outside of nephrology that talk about culture, distrust of the healthcare system given a lot of inequities or biases against blacks in this country, spiritual reasons, health literacy, et cetera. But it also brought up this question, at least in my mind, of provider bias, which is something that makes all of us uncomfortable in thinking of whether a physician may not offer, the same palliative resources, so hospice or withdrawal of dialysis, as opposed to other racial groups. Again, we were limited in that, but it was things that we postulated about in terms of what was driving these decade-long disparities. So speaking about bias, I wanted to talk about a study that was published recently. And again, I know it makes many of us feel uncomfortable. We all, went into medicine to help people. And so you can't think of why someone would be biased in doing something. But this was published in PNAS in 2016. And the researchers basically wanted to look and survey medical students at the University of Virginia about falsehoods of biological differences between blacks and whites. And they actually surveyed blacks and whites in terms of the medical students, but really focused the analysis on white medical students. So first, second, and third year white medical students were surveyed, and they were asked about, in a survey of 15 items, about different biological differences between blacks and whites. For instance, do blacks have smaller skulls compared to whites? Do blacks have less sensitive nerve endings compared to whites? And they found that approximately 50% of students held one false belief about biological differences between blacks and white patients. And they were also asked to read 2 mock cases about a black and white patient who were in pain. And they found on this curve that the more false beliefs that you have, the less likely that you were to rate a black patient having pain. And so, again, thinking about the different biases that one may have actually translates into your thought processes in clinical care and actually what you will recommend for treatment, which is something that they also looked at. But they didn't find that same association when the white students were asked about white patients. So again, it was really an association that they found with black patients, which is very interesting. So how can we actually confront and decrease disparities in care? I like to start with the first strategy of checking your biases at the door, and arguably this is probably the most difficult thing to do. Again, none of us want to believe that we're biased. I was a sociology major. I love, thinking about how people interact with each other, but we are all biased. It's a human phenomenon. It's natural. We all come from different walks of life. We all hold biases. And if you read the works of Dr. David Williams at the Harvard T.H. Chan School of Public Health and John DeVidio at Yale, who are really lead experts in biases in healthcare, unconscious biases, or biases that we are not aware of, are what's driving health inequities, as opposed to conscious biases such as racism. And so the first step is knowing what your unconscious biases are. And there is a test that you can take online, the implicit bias test, which is available free of charge for everyone, implicit.harvard.edu, where you can take a number of tests that can identify biases against different gender, religion, race. It's very, very profound, and it's at least to acknowledge what your biases are before you do a clinical encounter and engage with a patient. It's really helpful to know exactly what those are. The final strategies I've borrowed from the Institute of Medicine, again, Equal Treatment publication in 2002. And strategy 2 would be to strengthen the stability of the physician-patient relationship. And so when I presented that sickle cell disease patient, there was a lot of clinicians, or some clinicians involved in her care, that expressed frustration with her. Why is she a frequent flyer? Why is she coming back to the hospital so many times? Like, what's wrong with her? And when I encounter patients like this, it's very easy to write off a patient to think that they're difficult. But actually sitting down and talking to her, she really told me how distressed she was. She needed help, essentially. And people were writing her off. And she actually was discharged during the time that I was taking care of her. And she went straight from her inpatient bed to the emergency room. She didn't even leave. She was still in pain, and she didn't feel like her pain was being addressed adequately. And so really taking the time out of your day to sit down and talk with that patient before making assumptions from things that you read in the clinical chart can be very helpful. And it's a bonus if you can bridge any cultural or linguistic gaps. Strategy number 3, I like to say, phone a friend, okay? Like, I am not the expert in social services. I'm not the expert in nutrition. I'm not the expert in psychological support services as well. And so really having implementing a multidisciplinary team approach is really what we can do to coordinate and streamline care, to enhance patient adherence through follow-up, and to address multiple behavioral and social risk. I've had patients like her before with sickle cell disease. They struggle a lot with the disease that they've had their entire life, and a multidisciplinary approach where you have a clear treatment plan can really make a huge difference in stopping the cycling of admissions, self-efficacy for these patients. That brings me to the next strategy, which is implementing patient education programs. Health literacy is something I've also studied in my work, and African American patients with kidney disease have a higher proportion of low health literacy compared to other racial groups that have kidney disease. So really tailoring your communication and written education to an appropriate health literacy level is really important in terms of translating this information and having them receive it. You'd be surprised how many patients actually don't understand what you're saying, and if you ask them, do you understand, nobody wants to respond with, I don't. It's embarrassing. And so another way to actually to address whether a patient has received educational information is to say, can you teach me back what you've learned today, instead of asking them if they understand. And then the last strategy is something that's been established in a lot of pipeline programs and a lot of research in other disciplines of medicine, but to really advocate for racial and ethnic minorities on the healthcare team. It's been shown that racial concordance of patient and provider is associated with greater patient participation in care, higher patient satisfaction, and greater adherence to treatment. So advocating from everyone on the clinical team to have a more diverse team can only be beneficial to the patient. So in summary, there are social and economic disparities in the United States that disproportionately affect minority groups. Social determinants of health and bias greatly contribute to the disparities in care that we see going on amongst African Americans in the United States. And there are numerous strategies that all of us can implement to improve care and simultaneously reduce racial disparities. So I'd like to acknowledge my mentors and collaborators. The list seems to grow longer and longer with each year. I also want to acknowledge the ASN Diversity and Inclusion Committee. It's an incredible group. I'm so proud and honored to work with everyone on it. My funding resources, and shameless plug, follow me on Twitter, Nwamaka EMD, and I'll take any questions.
There's time for a couple of questions.
Just real quick, I have a comment. I shared this comment last ASN, and I'll do it again. Okay. I'm often asked by my non-minority colleagues whether or not they are able to make the same connection with their minority patients as I might be able to, and I can appreciate where that comes from. I then remind them that I am in that situation more often than they are. Because the majority of patients that I see don't look like me. And so I help them to understand that minority patients are not looking for a provider who is black necessarily. They're certainly not looking for a non-black provider to act black, quote unquote, with them. They're simply looking for someone who can empathize with them, connect with them on a genuine level. Everyone knows what it feels like when their physician, their teacher, their mentor is paying them genuine attention and is genuinely invested in their success. I would argue that that same dynamic crosses all of the different aspects of diversity that this session is describing today. And I would encourage all of us to practice that and then take it to those of us, your colleagues rather, who are not in this room today, and encourage them to practice it too. Thank you.
Thank you for that comment. Dr. Unruh. Thank you.
I've a two-part question, I guess. So in your construct of social determinants, where does historical trauma fit? And then if you were going to design an EMR that collected social determinants data, what are the key factors that you'd include?
So where does that fit? I mean, I think if you could do a subdomain from everything that I listed, I think trauma would fit into all of them. So violence, I mean, food insecurity, I mean, those are all very traumatic experiences. We had a great discussion yesterday during the palliative care session about how patients can't conceptualize planning for care at the end of life if they can't even pay the rent. And so I think all of these social determinants of health have a subdomain of trauma. If I could design the perfect EMR for social determinants of health, I would want to collect anything, but I've been saying this to all my trainees, I really feel like when we're doing our clinical presentations that the finances piece just really drops out of the interview. And so it really drives so much of what patients are able to do, what they're able to focus on. So I really want to know, like, what can you afford? You know, how are you paying for your medications? How are you paying for your food? That's something that I routinely ask about. Yeah. Thank you.
Hello.
Hi.
I wanted to thank you very much for the talk. I'm a fellow, so still kind of just getting used to this whole reality and everything. But I wanted to comment about some experiences I had working in during residency in a primary care clinic in Harlem, where the patient population was predominantly black. One of the initiatives we had actually tried to do at one point, when we were realizing we were having very poor outcomes, there were a lot of problems that were very evident, just difficulty with getting medications filled, no-shows to appointments and things like that. And one thing we did is we decided to devote certain clinic visits to not just focusing on the numbers for not the hemoglobin A1C and not the blood pressure, and that visit was just 20 minutes of what are you actually going through, what resources do you need to be able to get your medications, what resources can we provide from a social work perspective and such. And unfortunately, I kind of finished residency while we were doing that underway, so I didn't really get to see the fruits of it. But one of the problems is that it felt like there's no, right now all payment and everything in medicine is very focused on numbers and meeting quality initiatives, which is like very good nature. It's well-meaning because you're trying to meet numbers that we know work scientifically, but how do you, what could be a way to divert the attitude so that instead of the funding being just for numbers, that you actually focus on things like social determinants and have that be compensated for so that it's not ignored, what kind of an impact it has?
Yeah, so there is a patient education billing code, and so I routinely include that in all of my visits. I do exactly what you do. If there's a high social need, I bring them back frequently and we'll focus on that and how I can help them. I phone a friend. I think that's really important, and get social work involved, case management involved. But there is a patient counseling billing code. How much does that bring in compared to like a level 4 visit? Probably not much, but you can add that. And I would probably encourage you to add that to all of your visits, since that's what you're doing.
Thanks. Great talk.
Thank you.
As you know, there are some people advocating for avoiding mentioning race and ethnicity when you do history and physical or ask medical questions or things like that. And then on the other hand, it's very clear that these are very important social determinants. So how do you reconcile
Yeah,
these things?
so that's a great question, and thank you for asking that, because I trained at a historically black institution for medical school, and we were in Meharry Medical College. We got Dr. Ray over here, who's also an alumni, and we were routinely trained to not include race in the clinical presentation. I think you can ask about social determinants of health without putting race in the clinical. I think putting race actually introduces more bias than not, and so you can still ask about social determinants of health. There's no, African Americans, Latinx, we're not a monolith, and so it doesn't apply to everyone in that racial group. You can just specifically ask, are you safe living at home? Can you afford your food? Do you have, can you a lot of transportation? Can you have transportation to your clinical visits? And address all of those same things without using race. I routinely do not use race in my clinical presentations.
Real quick, I
Yes.
just want to remind everyone that race is a social construct.
Yes.
It's not a real thing.
Yes.
So it is how we as a society describe people based on appearances, phenotypic characteristics that we associate with specific groups. And so I think demonstrating specific characteristics.
All right. No, great. Wonderful. Round of applause.